It is live streamed also.
Has Dr. Sangmitra joined?
Actually, ma'am is not feeling well.
Okay,
So,
doesn't matter. Doesn't matter.
She just informed me that she has
Okay.
cough and cold and
That's okay. That's okay. Should we start, Dr. Kaushik? You can start.
I think we can start. It's
Yeah.
1 minute past
Yeah.
7:30. Or we can, I think we can wait for a minute.
Sure.
Let
But
some
after
others join.
Okay.
I think we can start.
Sure.
Good evening, everybody. On behalf of Indian Public Health Association, we are going to observe the World No Tobacco Day. Actually, the World No Tobacco Day is tomorrow, that is 31st May, but we are observing this day a day before. But for me, the World No Tobacco Day is every day, not only 31st May. It is 365 days a year. We should follow World No Tobacco Day. We all know the harmful effects of tobacco, but still we are addicted to tobacco. WHO says grow food, but not tobacco. But still the things have not changed. So today we have with us two stalwarts with me in this field. One is Dr. K. Madan Gopal. He is advisor PHA, that Public Health Administration, in NHSRC, Ministry of Health and Family Welfare, and he was previously in Niti Aayog of Government of India. And we have also with us Dr. Sunila Garg ma'am, who needs no introduction. Every one of us knows her. She was HOD of many of the medical colleges in community medicine. Now she is in NIHFW and many other organizations. And she is also the chairperson of Indian Academy of Public Health. So without wasting much time, I would like to hand over to Sunila Garg ma'am for continuation.
Thank you, Dr. Kaushik. We are so much proud. I'm missing actually Dr. Sangmitra also, but very proud to have you as a very young, dynamic Secretary General. And without, I think that IPH Academy this year has started very soon with the, lecture series and plus the, all the academic activities. And I will say that we are very lucky that, Dr. Madan Gopal, who was earlier in Niti Aayog, could give us time for this very important session. And as you rightly said, every day is a no tobacco day. That's what is very important. And today we are going to talk about on a very, very important issue, because today is the eve of World No Tobacco Day. I see like this. So that's where it is so very important that, IPH is bringing into focus attention of this, so-called, I'll say practically, though it is addressed problem, but it is very difficult. We are talking about smokeless tobacco. Yeah, just now I went to Gorakhpur, I went to, so many places, and you realize that, women and men are taking just like that. They without even, they do realize, but they have their own myths and misconceptions without, kind of coming to a definite logic conclusion. So thank you so much, Dr. Kaushik, for inviting Dr. Madan, and it was so much in our mind of Academy to have him. So without wasting time, we'll go directly to Dr. Madan Gopal, who has been legend in the field of public health, I'll say like that. And as part of Academy, I am thankful to him for being here. Thank you so much, Dr. Madan. The floor is yours. And I'm seeing that gradually the participants are also joining. Thank you so much. Thank you.
Thank you, Sunila ji. It's a great honor and privilege. I am humbled by your words, but I'm doing whatever as a shoulder which I can contribute to the public health. That's one thing. I'm thankful to IPHA for giving this opportunity to share my views on the No Tobacco Day. Before I share my presentation, let us be reminded that tobacco is not an essential part of our body system. We don't require nicotine. Nicotine is not required for sustaining the body and the life. This tobacco was introduced into our country in 16th century. It was not indigenous. It was not produced for centuries. It was introduced in the 16th century, and after that we have been introduced to this. And now we are getting addicted. And one of the main challenge, whole focus was on the tobacco smoking and other things. But the smokeless tobacco, which is taking a menacing proposition, so it is more or less neglected. We have to see that how we observe this No Tobacco Day, say no to any tobacco products. And that's the whole theme of this. When I was discussing with when I am sharing this screen, when we were discussing with Mitraji, he suggested that I should be sharing some topic. So the topic which I suggested that at least we should tackle the menace of smokeless tobacco. And so that we can, at least if we are able to tackle to this, we can lead a path to health and well-being. So I would be focusing on that. And I think the screen is visible, and I would be quickly running through the presentation.
Yes.
So the screen is visible, but yes, it's now fully visible.
I know that.
Uh-huh.
Okay. Then
Thank you, sir. Thank you.
one of the important thing, this is the only product which is legally sold and used as intended by its manufacturers, but it kills half of its users. This is the cash thing, and we should be able to propagate this much. It is the only legal product which is legally sold and used as intended by its manufacturers, but it kills half of its users. Globally, tobacco use kills more than 7 million people every year, as per WHO stats. The smokeless tobacco, which I would be using SLT in most of the coming slides, was considered a harm reduction alternatives by several parties for a specific problem of, or it is considered as a specific problem of the Southeast Asia. Now you have to just see that the red words which I made, it was considered a harm reduction alternative by several parties. The smokeless tobacco use is becoming a global concern with more than 350 million smokeless tobacco users in 140 countries. That means from smoking, we have been shifting them to harm reduction alternatives. Now they are having this problem of smokeless tobacco users in 140 countries. Nearly 365 million people are consuming this tobacco. 140 countries, as I mentioned, while 82% of this burden lies in Southeastern East Asian countries, like it's India, Bangladesh, Pakistan, Afghanistan, and this area. I'm only focusing on this. Unfortunately, more than around a million people die every year due to smokeless tobacco use. India has over 26 crore tobacco users, cutting across all demographics and genders, and more than 10 lakh people are losing their lives every year due to tobacco-related disease. Apart from that, another increasing evidence which is coming is tobacco use is impacting the sperm count as well as the mobility of the sperm, as well as the increased use of tobacco is resulting in miscarriages among the women also. So this is not only causing cancer, but it is affecting the generations as well. Another important aspect is it reduces the hunger. As a result, you might have seen people chewing tobacco and they are consuming tobacco. They would be purchasing tobacco around 200 rupees per day, but they are not consuming any food. As a result, you will see a lot of our workforce, which is lean and thin, the skilled workforce, they are lean and skin, and they will only chew tobacco and they will just move around. India is a home to 119 million smokeless tobacco users. That is almost 65% of the world smokeless tobacco users live in India. So what is smokeless tobacco? The smokeless tobacco is better known as spit tobacco, chewing tobacco, chew or dip. User put tobacco leaves into their mouth and suck on them instead of smoking them in cigarettes. Even the simplest smokeless tobacco products are chemically complex, containing nearly 4,000 different chemicals. Many of them, they are toxic, mutagenic, and carcinogenic. And many of the time, we are not aware about this. The two most commonly used smokeless tobacco are, one is the kheni, which is mixture of tobacco and lime used by around 11.2% adults, and gutka, mixture of tobacco, lime, areca nut, used by 6.8%. In addition, about 6% of the adults use smokeless tobacco with butyl quid, while another 2.8% use it with pan masala. Both butyl quid and pan masala contain areca nut as an ingredient. Thus, more adults use smokeless tobacco with areca nut, which is class 1 carcinogen, than any other form in India. Now, let us understand what is the disease burden due to this smokeless tobacco. It contributes to the global burden of disease, disability, and death, with the highest burden on the India and Southeastern Asian region. Nearly 119, around 200 million adults in India consume smokeless tobacco regularly, and that is all either daily or occasionally. The use of smokeless tobacco is more than twice that of smoking. The number of smokeless tobacco users in rural areas is about 3 times than in urban areas. The all-cause mortality attributable to smokeless tobacco use in India was estimated to be around 3.7 lakh people, with nearly 3/5 of these deaths occurring among women. Sorry, it's not moving.
Have you shared the slides with us?
No,
Yeah.
now it's moving because
Yeah.
if I minimize something, so the slide usually gets stuck. Okay.
Okay.
Now let us talk about the economic burden of tobacco-related disease. The total economic cost attributable to tobacco use from all diseases in India, the study which was commissioned by Ministry in 2011 for person aged 35 to amounted to around a lakh crores, of which 16% was direct cost and 84% was indirect cost. Direct medical cost, cost of hospital care and treatment of tobacco attributable disease amounted to rupees 16,800 crore. You can imagine what kind of stress is there on the system if regarding the use of the tobacco in this. And the associated indirect morbidity costs amount to 14,700 crores. The cost of premature mortality was rupees 73,000 crores. As we know that among the NCDs, the cardiovascular disease shared the highest burden of direct medical costs and indirect morbidity costs on account of tobacco use, followed by respiratory disease, tuberculosis, and cancers. The estimate of 1,04,500 crores economic cost of was found to be 1.16% of GDP and was 12% more than the combined state and central expenditures on health in 2011-12. That should be more if do a new study in the current times. The total excise revenue from all tobacco products combined in 2011-12 amounted to only 17% of the estimated cost. After that, a lot of efforts were made, and there has been increase in the taxes, but the revenue of the government, as witnessed in the other countries where that excess revenue is used for healthcare, that kind of thing is not visible in our country. We have not been able to generate much revenue by increasing taxes and other things. So what are the efforts made by the government? If you talk about the efforts internationally, World Health Organization has evolved a framework convention of tobacco control. They have understood that the colossal threat of the disease and deaths caused by tobacco use, and all the countries they have adopted, many of the countries they have adopted this framework convention on tobacco control, which essentially asserts both demand and supply reduction measures to curb tobacco use in any form or of any type. WHO has included tobacco control in 16 essential health services monitored to achieve universal healthcare coverage. India being party to WHO framework on convention of FCTC and guidelines of Article 6 of WHO FCTC, we have been recommending increase in taxing to reduce consumption of tobacco products. In the current financial year also, in the budget speech, there has been mention of increasing the cess of the tobaccos to taking it to the WHO norm of 75%. But still, we have to reach that mark. Now, these are the key efforts which have been made by the Indian government, being signatory to the framework convention. Framework convention. Now, key regulations under the following regulation concerning smokeless tobacco. One is cigarettes and other tobacco products. That is, COPTA Act is there, which was enacted in 2003. And then the other measures are prohibition on use of tobacco and nicotine as the ingredient in any food under the Food and Safety Standards Regulation. These are the main two regulations which regulates the consumption of cigarettes as well as tobacco and nicotine in the country. Apart from that, we do have pictorial health warnings. The pictorial health warnings on tobacco products are notified first as a result of public health interest litigation, because positive judicial activism has been witnessed in this tobacco bans and other things. Most of the things which we are witnessing, most of the new additions, other things, a positive activism has resulted in all these things. In 2014, the pictorial health warning were increased from 40% to 85% of the principal display area. With support from Ministry of Health and Family, other government and non-government organizations, the National Tobacco Testing Laboratories and Global Knowledge Hub on smokeless tobacco are providing product testing facility, research, training, capacity building, and policy support for further strengthening of smokeless tobacco control program and its enforcement in the country. Ban on smokeless tobacco in toothpaste specific to smokeless tobacco use. You might have seen previously many of the toothpaste and tooth powders in different brand names. They used to contain tobacco, which used to give a tingy taste, and people used to get addicted to that. It was sold as a teeth whitener, but now a teeth whitener. But nowadays that has been banned. The ban on gutka, the Food and Safety Authority of India prohibited the use of tobacco and nicotine as food products. Since gutka is prepared after mixing sweeteners and condiments with tobacco, majority of the state government issued order notification under the FSSAI Act prohibiting the sale of gutka and pan masala containing this within that. In the Honorable Supreme Court, lot of litigations are there to challenging all these things. Then the progressive steps by the Indian judiciary, as I mentioned earlier, the Indian judiciary has been the pioneer in tobacco control and directed the state governments to curb smoking in public place, to prevent violation of non-smokers' right to breathe fresh air, free from tobacco smoke. Several subsequent litigations have also strengthened the smokeless tobacco prevention and control in the country, like decision of the Rajasthan High Court banning the use of plastic sachets to pack gutka and pan masala, ban on minors' access to tobacco products. Several high courts in the country have issued directions for protection of minors as envisaged under Section 6 of COPTA, ensuring no sale of tobacco products to and by minors and within 100 yards of educational institutions. Though these acts are there, progressive steps have been taken. But the saddest part is that the early initiation of our children to tobacco. If you go to any school, the person of 10 years, 11 years old boy or girl, they would be having tobacco products in their pockets. The early introduction happens because initially what I have witnessed is that people usually give free of cost to these children and they become their potential clients afterwards. The addiction starts from there. In fact, in our houses also, the grandparents and other things, this is an area where a lot of things is to be done because we are talking about the future generation. If you look at the way, you should not be asking our children to go to the vendor shops or the pawn shops to bring tobacco products for them. One should never do that. And because the moment the child goes there, obviously he would be attracted, and there are many multiple social factors are there in the coming. When we talk about the way forward, then we will be talking about this as well. Then this is the National Tobacco Control Program. It envisages to have continuity in all the districts as well as the cessation centers in each district and all dental college. The tobacco control is a centrally inspected scheme, and you see the National Tobacco Control Cell is there. Then at the state level, state tobacco control cell are there, district tobacco. This is the mechanism which is available. Then yes, the major components of the National Tobacco Control Program are there. Now all these major programs, they would be a part of a wider program, NCT program in the coming years. But now it's a major verticality is there. The tobacco cell is there. At the lower level, training, what we do at the state level, the State Tobacco Control Center, it is responsible for training of the stakeholder, state level, public level awareness, IC campaign, monitoring tobacco control law and reporting this. At the district level, the District Tobacco Control Cell, they are responsible for training and capacity building of the medical officers and the others. School awareness programs, setting up and expansion of tobacco cessation facilities, IC media campaign, monitoring and enforcement. You'd be surprised that we are conscious of the nicotine replacement thing, and the nicotine replacement, they have found place in the National Medicine Essential List, which has been notified last year. So what are the challenges? One of the interesting challenges, the high and the merit base the smokeless tobacco use in India and in the region. It is the biggest barrier in this. Most of these products contain extremely high level of nicotine, resulting in chronic dependence. The introduction starts from the childhood. If you go to any school, that's why the school health program, which has been revisited, that becomes very important, because we have to teach them, raise awareness, and prevent this chronic dependence. We have been fortunate that our demographic dividend is very good. But if you look at the BMI of the people, it would be less than 20 in majority of the cases. It focus, and major is people don't eat. Why? Because in the rural areas, the consumption is high, and they are introduced to that since their childhood. That is as early as 8, 9 years, 10 years. So do you want that kind of thing? And this is the major barrier for this. Most of the smokeless tobacco products are produced in traditional markets such as cottage industry and household level in an unorganized sector, and remain away from regulation, and thereby greatly vary in their composition and the health risk. So efforts have been made to how to bring them into the fold of regulation, but still that's the biggest challenge. The interference by the smokeless tobacco industry in development and implementation of effective SLT control, especially by lobbying, tax evasion tactics, litigation against promising policies, has prevented the desired effects of such control policies. And just citing an example, when I was tasked with to do a desk review, there were so many lobbies trying to influence and see that their voice and other things are heard. And if you don't hear it, they will try to see that they will make allegations, they will make complaints, and that kind of tactic they usually have. As a result, if you want to have an implementation development, we have to see that how you circumvent all this tactics and litigation and the promising policies which they make. The other important challenge is the socio-cultural barriers related to smokeless tobacco use. For example, social acceptability resulting in early initiation, as I mentioned earlier. In the rural areas, it is quite acceptable to offer tobacco, and there's betel nuts. It is resulting in early initiation, and they are getting addicted and hooked to that. The structural barriers, for example, lack of resources, training, and capacity for enforcement of smokeless tobacco control laws. Policy initiative includes cessation support, understanding of the market and supply chain of myriad varieties of smokeless tobacco, their content, animations, aggressive surrogate and indirect advertisement by the industry. You have seen during the IPL, you have seen even the West Indian cricketer, he is promoting this advertisement of this tobacco in a surrogate way. The access and exposure to minors, online sale, promotion, and lack of economically viable alternative for those engaged in growing and producing and retailing smokeless tobacco products in the country. One of the interesting aspect is most of the agriculture produced in the country comes under the agriculture ministry, but the tobacco cultivation and other things, they come in this. So efforts are being made to see that how an alternative option is given, so that the farmers who are involved in this tobacco production, they venture out and they diversify into other crops. The way forward, the recourse to litigation and positive judicial is one of the most effective tool to meet the public health objective. That we have been able to showcase that thing. Previously, during my childhood, we used to see a lot of people smoking in the public places. Now it's very difficult to find or spot one person who is smoking in public places. Otherwise, previously it was very difficult to travel in buses and the trains or going to a cinema. You will be finding a lot of smoke in that, because people used to sit there and smoke. But after the litigation and the positive judicial intervention and enactment of laws and acts, now you see that kind of positiveness. Now, if you look at the way things have happened, there has been reduction in the people who are having smoking, but they are now going into the alternative mode, and we have to be very conscious of that fact. Standardized packing of the smokeless tobacco products, contrary to the preparation of Article 16 of WHO FCTC, are generally sold in small box at very low price, resulting in high access to minor and negligible impact of tobacco taxation policy. Why? Because we have been increasing the taxes, but there is negligible impact on, because the people who are consuming this. India, we are having the problem of smokeless tobacco, not the smoking tobacco. The smoking percentage is now coming down, but now we are uh, now the smokeless tobacco is staring us, and we have to see that how we address this problem. So the next challenge, logical step for the government should be to standardize the packing of all tobacco products, including smokeless tobacco products. Prohibit branding, stretching, or brand sharing of tobacco products. Majority of are consumed along with Arshia nuts products, and it's engaged in manufacturing and sale of several gateway products with Arshia nut as a key ingredient. For example, pan masala, meaty supari, mouth fresheners using the same brand, color, design. That is established. Therefore, registration of any tobacco brand for non-tobacco products should be prohibited by trademark authority. This is very important. Otherwise, the whole of the TV and the commercial, they are flooded with surrogate examples of that particular brand. And people, the moment they go there, they have been offered that particular brand which contains tobacco. So this is to be prohibited. No additive, scents, sweeteners, or flavoring should be used as ingredient in tobacco or nicotine products. It should not be made this. It should be bland product. As per FSAI guideline, tobacco and nicotine cannot be used as an ingredient in any food item in the country. But still, most of the smokeless tobacco products are sold after processing and mixing additives, scents, sweeteners, or flavoring. That makes the tobacco products palatable and pleasant for consumption, especially for young and minors. Now, we are trying to see that how our guidelines and other things are good, but many of the things, tobacco as an ingredient and banning of the tobacco, a lot of litigations are there in front of the Honorable Court, and after the decision, I think some more things would be visible. Then one of the important thing is how to protect our minors and minors. We can do it by increasing the legal age for sale of tobacco products, as done not as in the countries elsewhere, like New Zealand. The people who are born after a certain day, they are not they can't buy tobacco during their lifetime. They can't be having this. So if we are able to increase delay the tobacco use beyond certain limit, there's chances that the users would be reduced in the coming day. But the main problem is the societal acceptance as far as early initiation of these people, as early as 8 to 9 years or 10 years of age. So that's the biggest challenge. Then strengthening tobacco cessation services. We do have cessation centers in most of the districts. We do have in the essential medicine list the nicotine patches and other things are there. But we have to see that how we can reduce the demand for tobacco products. That's a challenge. So that not only the health department, but the other departments also should product reduction in the demand of the tobacco products. We need to have a comprehensive approach for the smokeless tobacco taxation. Many tired systems of taxation there, mainly on the cigarettes and other things, but we have to see that how the smokeless tobacco is also brought into the tax gamut. Presently, since as I mentioned earlier, it is the cottage industry and the small unorganized sector. It's very difficult to regulate these people, but we have to make a comprehensive approach to bring them into our taxation network so that it disincentivizes people to venture into this. As somebody rightly says, as Mitraji has stated, that farmers should be producing food, not just tobacco. That's a different thing. Then retail licensing for sale of tobacco. Retail licensing will limit the number of tobacco vendors and help in ensuring compliance and with the tobacco. These are all the things which have been suggested, and let's see that how many of them would be used and implemented. That's the other challenge. Now, the major problem with the menace of this smokeless tobacco is that unlike the public movement against the smoking, especially in public places, the hazards of smokeless tobacco use have received little attention from public. Researchers and policy makers alike in a region where smokeless tobacco use is more prevalent than smoking. although countries in this region have taken steps to curb smokeless tobacco, they are yet to meet the WHO recommended standards on various articles of WHO FCPC. This is very important because smoking, they could correlate with lung cancer. But with this smokeless tobacco use, we have to make the people aware that it is causing dependence. So people are getting addicted to that. If you talk to any surgeon or an orthopedician, he will tell that if the person is having a history of tobacco consumption, the healing and the wound healing and the bone healing is delayed. If you look at the way the infertility clinics have come up, then if you take the history and correlate with that, you will find that majority of them, they would be consuming tobacco, because tobacco and nicotine is known to cause reduction in sperm count, as well as it influences the mobility of the sperms. And women who are consuming this tobacco, or as quite prevalent in the rural areas, the miscarriages are there. In most of the time, it's not reported. So these kind of problems are there. Apart from that, they are causing dependence. You see, for the morning rituals or the morning course, which you go to the rural area, they have to take tobacco to relieve themselves and to start the day. That kind of dependence is there. And we should always remember that it was introduced in our country in the 16th century. And since it has come from outside, now we can see that how we can avoid that thing by promoting good practices. Then strengthening the smokeless tobacco control programs in the region would further require multi-stakeholder research, training, enforcement, and policy action that is supported by adequate human and financial resources. The moment you talk about the smokeless tobacco reduction in tobacco, there would be a lot of lobbying, a lot of people will be coming, even the medical fraternity coming, saying that the person should be having right to choose. So right to choose, he's having the right, and other thing. That kind of debate will always go on, but we have to see that how we balance it out and strengthen the smokeless tobacco control program. There's a need for implementing innovative and evidence-based strategies, including ban on promotion and sale of smokeless tobacco products via the internet, while preventing the introduction of any new variety of smokeless tobacco. This is more important, because when one product is banned, they will find a way to introduce a new variety of smokeless tobacco or any other novel way of imitation of products in the market. And the advertisements and other things, they are all, you see, the names are there, and if you go to that kind of thing which they are promoting, that is not available. Instead of that, the person is given the tobacco product. Life cycle based approach is the need. We have to see that right from the tobacco cultivation to tobacco manufacture to tobacco marketing and to tobacco use. At all stage, an opportunity is there for specific intervention. We can partner with the various stakeholders for an integrated smokeless tobacco control prevention strategy as well. That is which would be ideal. So on this, on the eve of the observation of No Tobacco Day, I think we should take pledge and see that how this awareness about the use of tobacco products and other things is disseminated wider, so that the future generation, whom we claim that they are the future of our country with a large demographic dividend, we see that their BMI is improved at least more than 20, and they are healthy, and so that they can contribute better for the nation growth and other things. I stop here. Thanks again. Thanks again for this opportunity. Thank you very much.
Dr. Kaushik, you will take first.
Yes, sir. Yes, ma'am. Thank you, sir, for your excellent deliberation and insight on smokeless tobacco. And there are audience who are watching over the YouTube also and over here in the Zoom platform. So if you have any queries, because sir is with us, we are honored to have sir with us. If you have any queries, please you may ask sir, or you can put it in the message box. Yes, I can see one query has come from Mondira Biswas. She's telling, I have always wondered why isn't government putting a ban on tobacco? there is no good about it.
As I mentioned, we have to take a life cycle approach, right from tobacco cultivation to the tobacco use. Because there are many people, we have to see that how we balance it out. There are harmful effects of the tobacco. If the demand reduces, we are just focusing on reduction of the demand. We are educating the people so that they don't consume tobacco or tobacco related products, so that we can motivate the cultivators to venture into or diversify their crops into this, diversify their crops and have more other type of crops. But outrightly banning is not the solution, because livelihood of so many people is related to that. Our industry is so we have to see that how we balance it out. So best way is to disincentivize the people not to go for these tobacco products. And when the demand is not there, the market will always try to diversify and other things that do happen.
But Dr. Madan, I also will have one more point to say that, it worries that, if we have a return on investment of when we are talking of betel leaf, when we are talking of, gul, zarda, all these products, which are culturally also acceptable. But then, if we empower people that, this is the single most cause of mortality in our, Southeast Asian context, that is important, and not only Southeast Asian, rather Asian context, where we talk of, Pakistan and other countries as well. And another important harm is that, when you pointed out very rightly, sale to minors by minors. This is very important. And one of my studies pointed out, with children as young as in 4th to 5th classes, they start consuming because, they're seeing their teachers also doing the same thing. So, a lot of lesions related to leukoplakia or cancer of the mouth or other cancers, there's no part which is not affected by this. So I feel that if we talk in terms of return on investment, which I'm sure you have touched at various points of time, otherwise also during our discussions, that will be much better. That's where we say that we give them food and not tobacco. That's it. Thank you so much. Thank you.
But again, I said this, there should be a balance between life and livelihood, as Dr. Madan Gopal sir has said. That there are so many livelihoods who are related to this.
Yeah, but then that's what I'm telling. We have to ultimately look at return on investment and work on the alternative livelihoods as well.
Okay.
As of now, this seems to be a distant goal because, there are a lot of, if I will talk to my neighbor, they'll say that I take smokeless tobacco because this helps in digestion, this helps in, like this. But if you talk to antenatal women and all that, they do understand. But they say in my family, everybody is eating. But then if we look at the outcomes, stillbirths, abortions and all that. Now, NICPR has also launched a study, but we have to somewhere raise this at a policy level. That will be very important, and no other better person than Dr. Madan is there himself, has been there.
Madam, I entirely agree. We are conscious of this fact that this is more or less, but what is the solution? The solution is people should come forward. You see the way the e-cigarettes are there. E-cigarette is banned, totally illegal in the country, but still it is available.
Yeah, but
It's
we have to raise the awareness level to such an extent that people should avoid using all these products. And that's the biggest challenge. That means we should not be, as you have mentioned, the children who are getting addicted to that. If the children usually see and they learn. If they don't see us smoking, if they don't see us chewing tobacco, if they don't see us into any other vices, then they can obviously go into that.
Okay, there is another comment
Yeah.
from Tina Mitro. She says that a multi-sectoral concerted efforts may prove beneficial. At the same time, HRs, for example, school counselors, ARSH counselors, Red Ribbon Club members, etc., other programs may be utilized for BCC purpose, especially for the youths in this regard.
It's a good suggestion. I think at many of the places they are already doing this. They're trying to bring in, because it is the biggest example of multi-stakeholder is the WHO, this FCTC, wherein civil society, the different government, different agencies, they have been brought together. Similar kind of thing is also happening. It's not a single person effort or single department effort. We have to work together. You have to see that how all the people are brought together towards a common goal that the people should be
Yes.
made aware not to consume tobacco. We can't stop them. We have to only make an awareness so that they can take an informed choice that they should not be indulging into tobacco.
Yes, actually, there are so many stakeholders in this regard. Not only one or we ourselves can do it. We have to
Definitely.
bring all of them together.
Yeah. There was one question on taps as well. I think Dr.
Okay.
Just have to get that. In chat box, I think some.
Okay. Sir, could you throw some light on taps as far as advertising is concerned?
It's a very different question. I am not the right person to. I am not the right person to, because you look. I feel very sad in with the celebrities, though the Broadcasting Corporation and other thing, they have come up with this SOPs that the celebrities who are endorsing this kind of thing, they should be at least uh, going beyond. At least they should be knowing about the pros and cons of that products and other thing which they are endorsing. But they are not taking. It's all money game, and the person who is paying more, and they could open even the West Indian cricketers and other thing where the tobacco consumption there, the smoking is the problem there. But he's also coming and giving an advertisement to what we can say.
Yeah, another thing is also, Dr. Kaushik, that when we look at tobacco advertisement, promotion and sales, we have to go as per norms, that the advertisement has to cover almost 80% of your pack. That is important
Yes.
part. And this is, and that is true when we are talking of the, packet of cigarettes. And the same thing, if you look in context of smokeless tobacco, everything is very much fudged. No advertisement is clear. Even if you can't read, is injurious to health and all that. So this is where, under the garb of promotion and all that, they will put some picture. But if you look at, they're supposed to very clearly put how oral cancer looks like, or other pictures related to that, and the picture has to be very clear. So that's where it is important to look at that how do we catch hold of these manufacturers and tobacco industry as a whole. When we talk of pan masalas and all that, ultimately, in the garb of pan masalas, you're selling this pichku, which is tobacco. So that's where we need to be very careful exactly, and about the promotional strategies with regard to advertisement also. And when, Dr. Madan pointed out himself that, when celebrities are coming forward, which is a common lure for a common man, that is also very important to look at, that why do we, kind of do not take action against this part also. This is very important. Thank you.
I think we are running short of time, and we had a very good discussion today, and we are honored to have Sir and Madam with us. And we have missed our President Madam, Dr. Sanghamitra Ghosh, because of her illness. But we are planning to have such more CMEs in future for the members and those who are with us, even not being a member. Please be with us and have these CMEs in different days. Thank you all. I think we can close it now because there are no more questions over Zoom and YouTube. Thank you, sir. Thank you, madam. And thank you all the audience for being with us.